For my history and physical presentation, I'll be presenting a 44-year-old female, African American female, um, who was admitted for altered mental status and unresponsiveness. The history of present illness includes a 44-year-old female with a past medical history of scleroderma and hypertension. She was brought into the ER by family members who felt she wasn't acting herself. 2 weeks ago, she received a flu shot and developed nausea and vomiting afterwards. Her PCP gave her some medication that helped until last evening. The family reports she was spacing out and was mistaking her telephone for a remote and not conversing very well. Patient went to sleep, and when family awoke her this morning, she developed seizure-like activity where she looked to the left and started convulsing. 911 was called, and EMS found the patient unresponsive with a respiratory rate of 30. Per the ER physician, the patient was intubated due to her combative activity and risk for losing her airway. Her past medical history includes scleroderma, hypertension, and pulmonary arterial hypertension. Her past surgical history includes a pericardial window secondary to cardiac tamponade. And her current home medication list included captopril, 25 milligrams TID for scleroderma and hypertension, sildenafil, 20 milligrams TID for PAH, macitentan, 10 milligrams POQ day for PAH, and prednisone, 7.5 milligrams Q day for scleroderma. Her current allergies include nothing. Her health maintenance, the last physical was within 6 months ago per the family. Family history, pertinent family history included mother is a lung cancer survivor, and one of her siblings has a seizure disorder as well. Her social history, there's no history of tobacco abuse, alcohol, or illicit drug use. Review of systems, was unable to perform. She was currently intubated and sedated. Physical exam, in general, she's lying supine in a hospital bed, currently intubated and sedated. Vital signs, pulse 94, oxygen saturation 94, temperature was 34 degrees Fahrenheit, respiratory rate 12, and blood pressure 188 over 18. Over 118. Skin was dry, no bleeding or drainage. HEENT, normocephalic, atraumatic, pupils pinpoint, ET tube in place. Neck, no thyromegaly, no carotid bruit, no JV distension, and no extended neck veins, which is JV distension. Respiratory, she had decreased breath sounds at the right base with a few crackles, no audible wheezing or rhonchi. Cardiovascular, she had a regular rate and rhythm, S1 and S2 without murmurs, rubs, gallops, or clicks. No peripheral edema was noted. Breast, no gynecomastia, lumps, or nipple discharge. Abdomen, the bowel sounds were positive, normal active, soft, and non-distended. She was currently MPO. Rectal, no masses or bleeding visible. Musculoskeletal, she had bilateral wrist restraints. Mental status was sedated. Her RAS was -2. She moved all extremities with a sedation vacation. Not on command, though. Her laboratory data includes her WBC is normal 5.4. Her platelet count was low, 112. Thrombocytopenia often precedes a sclerodermal renal crisis, which she was being worked up for. Her CO2 level was 15. Serum CO2 was 15, so it was decreased, probably from hyperventilation. She had come in with a respiratory rate of 30. Her BUN was elevated at 48, probably from renal failure. Creatinine 1.94, elevated, renal failure, sclerodermal renal crisis. Glucose normal 145. Her anion gap was elevated slightly at 17. So she could have anion gap metabolic acidosis related to ischemia or lactic acidosis. Her lactate level was normal, 1.3. Lactic acid, 10.2 normal. Troponin T was elevated, 0.127, probably related to renal failure and a hypertensive crisis. But you cannot rule out an MI, so we must obtain an EKG. BNP was elevated at 6,500, related to pulmonary hypertension, fluid volume overload, possible MI. PTINR was slightly elevated. PT was 15.8, INR 1.3. ABG, she was acidotic, pH was 7.323. PCO2 was decreased 27, again, probably from hyperventilation, but she was presenting with respiratory acidosis. Bicarb was 13.7, so she could have a mixed respiratory and metabolic acidosis. The metabolic acidosis could be from the renal failure and lactic acidosis buildup. Her UA, the specific gravity was 1.008, which is low, indicates dilute urine. Blood, she had large amounts of blood in the urine related to renal failure. Protein, there was trace amounts, RBC 6 to 10, elevated related to hypertensive nephropathy, renal failure. WBCs, normal 2 to 5, which indicates an absence of UTI. However, there was moderate bacteria present, which indicates a possibility of UTI, so she was started on empiric antibiotics. Granular casts 0 to 2 present. Granular casts are present in lupus nephritis, typically with red cell casts, white cell casts, and oval fat bodies, and granular casts in an equal perfusion, which she did not have. However, you cannot rule out lupus nephritis, so she was being worked up for that as well. To diagnose lupus nephritis, you need a renal biopsy. She's currently on mechanical ventilation, volume controlled, and it was 500 liters volume, PEEP was 6, and FiO2 100%. The problem list assessment includes acute stroke, acute respiratory failure, acute renal failure, elevated troponins, lactic acidosis, scleroderma, and malignant hypertension. The treatment plan involved, for acute stroke, to control the blood pressure, we were going to increase our captopril to 37.5 milligrams TID. She was past the window to receive TPA. Acute respiratory failure, continue mechanical ventilation, wean off vent with Precedex, start empiric antibiotics, pulmonary consult, obtain sputum culture for gram stain, culture and sensitivity, and blood cultures for sepsis work prior to starting the antibiotics. For acute renal failure, we were going to trend her creatinine, obtain a renal ultrasound. The family had informed us that she was scheduled for a renal biopsy next week at UT Southwestern, and they were going to work. That renal biopsy was to determine if she had a sclerodermal renal crisis versus lupus nephritis. We needed to obtain a urine sodium, chloride, potassium, and creatinine level, urine antigen for pneumococcus and Legionella. So we placed a nephrology consult. For the elevated troponins, we went to trend the troponins, obtain an EKG, and maintain tight blood pressure control because the troponin could be elevated from the hypertensive crisis. Lactic acidosis was related to her acute respiratory failure. She's currently on a bicarb drip. We need to repeat her lactic acid level to check that. Scleroderma, continue the captopril, which is the treatment, but we're going to increase the dose and also continue the prednisone, 7.5. For malignant hypertension, continued tight blood pressure control. She was currently on a Cardine drip. Restart statins when no longer MPO. Start aspirin rectally since she was MPO. And as I said, continue the Cardine drip to titrate systolic blood pressure less than 160 millimeters of mercury. The seizure was probably related to her hypertension. So we continue tight blood pressure control, obtain an MRI of the head and neck to rule out blockages, and obtain an EEG status post seizure, determine if there was any damage done to the brain. Consults placed, ID consult for sepsis, possibly UTI. It would be helpful to obtain a procalcitonin level to determine if she was septic. And again, we're waiting on the UTI result, or we got the UA. Okay, so pulmonary consult for renal failure, pulmonary consult for respiratory failure. Nephrology consult was for the renal failure. cardiology consult for elevated troponins, like to obtain an EKG prior to placing the cardiology consult, so that they had that to review. And disposition was to continue close monitoring as this patient is at risk for further deterioration. Thank you.